Hi, Dr. Weinstock,
Good
calling from
afternoon.
a cloudy day in St. Louis, and here we go for my intros.
Good afternoon, and thank you for joining the RLS Foundation's webinar titled SIBO, Diet, and RLS. My name is Carla Ron Phillips, and I chair the Board of Directors of the RLS Foundation's Board of Directors. Before we begin, please be aware that all attendees will remain on mute during this hour. We thank you for the questions submitted with your registration. Dr. Weinstock will answer as many questions as time allows at the conclusion of his presentation. The surge in the use of web-based programs during COVID-19 health crisis has created a strain on the system. If you're experiencing technical difficulties, switch to audio using the telephone number listed on the invitation because it uses less bandwidth, and be sure that your webcam is turned off. We thank you for attending and appreciate your patience and understanding with any technical difficulties that may arise during today's webinar. After the webinar, you'll receive an invitation with a link to the webinar recording. The webinar recording will also be made available in the member portal section of our website. If you're not a Foundation member, and if you would like to view this and other recorded webinars, we invite you to become a member today by going to www.rls.org. As always, individuals suspecting that they may have RLS should consult a qualified healthcare provider. Information offered in this webinar is for informational purposes and should not be considered as a substitute for the advice of a healthcare provider. Our speaker today is Dr. Leonard Weinstock. Dr. Weinstock has a clinical teaching appointment as an associate professor of clinical medicine and surgery at the Washington University School of Medicine in St. Louis. Dr. Weinstock's lectures and research have been presented at national and international conferences on diseases of the esophagus, stomach, small intestine, and colon. He is actively researching the connection of the gut and small intestinal bacterial overgrowth, SIBO, with several medical problems, including restless leg syndrome and chronic pelvic pain syndromes. Dr. Weinstock, we thank you for sharing your time and your expertise with us today. I now invite you to begin your presentation.
Thank you, Carla. Appreciate it. Well, I hope you'll gain some information about restless leg syndrome and the role of diet. Not much has been written about it, but from my research on the relationship of the gut to restless leg syndrome, I think we can draw some additional revelations and ways that you could perhaps make some connections in your own body and try to make changes in your diet that will help. Not on these slides are some of the work that I've done on restless leg syndrome and mast cell activation syndrome, which deals with histamine foods and the effect of histamine and thousands of chemical mediators that can cause inflammatory and allergic changes in people's body. And we just did a study of mast cell activity in restless leg syndrome, and percentage of people studied with mast cell activation syndrome, how many people had restless leg syndrome, and found a very important correlation there. So we're going to go to the first slide, which gives, when you are Googling and you go to the Mayo site, this is the advice that you get with respect to what things can worsen your restless legs. And it's fairly limited. So we got caffeine, alcohol, and tobacco, but that's not all. So I do want to foreshadow the specific discussions on specific food groups with a review of restless legs pathophysiology, iron, importance of iron, the role of SIBO, obesity, inflammation, And other topics will go into the specifics: gluten, vitamin D, magnesium, and caffeine, alcohol, and different sugars. So what goes into a person's body? What goes on in their pathophysiology when things are going wrong in their body? Well, we know for sure that CNS iron deficiency is well described as a major factor, and they've studied that with MRI scan and of course with the ferritin levels. Altered dopaminergic systems are essential, and that's been studied in a number of different ways, including animal studies. Peripheral neuropathy is often neglected as a cause of restless leg syndrome, and we do see a fair amount of peripheral neuropathy in mast cell activation syndrome, a very common condition that's rarely diagnosed but is highly prevalent and significant. There's a number of studies on genes which increase the risk for restless legs, but we don't know really why that is the case. Why do you have one GWAS type of arrangement in your body of different genetics, and why does that predispose you to getting RLS? We just don't know. SIBO is something that I've studied for years, since 2005. And then Dr. Walters, Arthur Walters, the beginner of the International Restless Legs Study Group, who's active researching, and we do research together as well. And he's putting out papers on a regular basis on restless leg syndrome. He and I got together in 2012 and talked about inflammation and immune disturbances in secondary restless leg syndrome, and found out they were so incredibly frequent. And then he studied, prior to that, endorphin deficiency, which plays nicely into one of the treatments I love for restless leg syndrome, namely low-dose naltrexone. So, as I said, iron deficiency is important. If you low in iron in the brain, then the dopamine cells don't work well. It has been looked at, including in the autopsy study, that there were increased levels of hepcidin on the brain membrane. So the entry into the brain, investigators looked at hepcidin, and the levels were increased. Well, with hepcidin, that decreases the transportation of iron across membranes. So in our gut, which is a membrane, if there's excess hepcidin going around your veins and your arteries and your capillaries, well, that tells those membrane cells to stop absorbing iron. We've got enough iron, don't absorb more. So it's actually a hormone that has important features, and we'll look at this in a second. And then interestingly, in mice who have are studied for CNS iron, it fluctuates. So at night, they actually decrease the amount of iron in their brain. And if you want to make a comparison, maybe that's why human beings have restless leg syndrome at night. They have less iron availability to those dopamine cells. So hepcidin is a regulator. In Dr. Walters and my studies of inflammatory GI diseases, we put this as one of the reasons why we think that restless leg syndrome occurs, let's say, in Crohn's disease, where patients with Crohn's disease, when they're in a flare, will have restless leg syndrome. When they get improvement and get out of it, they have less. And so therefore, more inflammation systemically reduces outflow of hepcidin from the liver, and therefore, the hepcidin actually is increased in the setting of inflammation, which decreases iron availability and transmission and transportation. What about iron and restless leg syndrome? Here's one paper looked at either oral or intravenous supplementation, and it looked at patients who developed restless leg syndrome because they were Good Samaritans and they donated blood. And so in these 176 Good Samaritans with iron deficiency, their ferritin was low as expected. They were treated in comparison groups of iron given intravenously or orally, and there was a significant improvement no matter what if their iron levels got up, and it didn't matter how they got it. So if your doctor says, well, your ferritin's 40, it should be above 50. In fact, it should be 75 and above. You know, you could take pills. That's a good, reasonable advice. You don't have to get it intravenously, but you can. But insurance doesn't cover it unless, you know, a particular set of questions have been answered. You know, are you anemic? Can you not tolerate oral iron, et cetera, et cetera. Here's another study looking at the patient characteristics predicting a good response to intravenous iron. And here they had a large number of patients, 164 patients. They checked their severity score before and after iron, and the responders definitely were the ones who were women who had low iron levels. Curiously, not the men. And so their conclusions was that iron in moderate to severe restless leg syndrome given intravenously was very effective as first line or even an add-on therapy. Let's go to the gut, my favorite organ, being a gastroenterologist. The following things in orange, those circles, are things that keep the bug count down in the small intestine. So for instance, if you make acid, then the bacteria that you swallow get killed off and don't go into the small intestine. If you've got good absorption, such as not having any changes to the villi that absorb iron in the duodenum, then great, that prevents problems. But if you were to have, let's say, celiac disease, you couldn't absorb the iron and you would develop SIBO because the bacteria are fed undigested gluten, and then those numbers of bacteria increase. And what happens next? Then the bacteria bind to the lining of the small intestine, you get bacterial overgrowth. Same thing for the pancreas. It has to be well functioning, otherwise pancreatic insufficiency. EPI, which the drug company that deals with EPI is doing a good job making people aware of exocrine pancreatic insufficiency, and sometimes it just sneaks up on you when you're older, or maybe you've had a history of chronic pancreatitis, relapsing pancreatitis that wiped out your pancreas. Having good immunity is important to keeping bacterial overgrowth away. Having a surgical, being away from a surgeon and getting your screening colonoscopy so you don't get colon cancer, and have the ileocecal valve removed prevents retrograde movement of bacteria into the small intestine. And then finally, the motility in the small intestine is critical to keep the bacteria flushed out. I'll go into that in a moment. So what is SIBO? Some people say, why aren't you saying SIBO or SIBO? But it always came out as SIBO to me and others, so that's the name. Basically, it's prevented naturally by the body functions that I just reviewed. But interestingly, there are over 40 different causes for SIBO. It can be diagnosed by the breath test, There are differences that your doctors will tell you. Lactulose is not as accurate, too many false positives, but there are false negatives if you do a glucose breath test. And very few places actually go down into the small intestine and put a catheter and suction out fluid anaerobically and send it off to a lab immediately to come up with the colony count. So the breath tests are ways to do it non-invasively. On the right, it says the symptoms, the typical symptoms: bloating, gas, abdominal pain, altered bowel habits, malabsorption when severe. But I should have done ... or none at all. So you don't have to have any symptoms with SIBO. You can just simply have it, and it can cause inflammation, but it cannot necessarily have to cause GI symptoms. So the next step that's really exciting to me is that you can have significant inflammatory conditions going on because the bacteria adhere to the wall, create inflammation. They draw in the mast cell, M-A-S-T cell, and the T cell lymphocytes and the B cell lymphocytes. And these are the three principal groups of white blood cells that create damage locally, but also symptomatic changes elsewise by production of cytokines, namely the inflammatory chemicals, and also by autoimmune antibodies, and by chemicals created in the mast cell. And that mast cell can, as I said before, produce 1,050 different chemicals that can cause major problems, ranging from head to toe in 11 out of 11 systems. And again, in the study that I did, 40% of my mast cell activation syndrome patients had restless leg syndrome. Here's the basic categories to understand SIBO. Anatomical disorders actually used to be much more common, although with right colon cancer or resection of the right side of the colon and end of the ileum with Crohn's disease, we still get causes for SIBO. Immune deficiency, a little less common, but things like CLL, leukemia can do this as well. Maldigestion, I mentioned the diseases most common for that, namely celiac disease and chronic pancreatitis. Achlorhydria, a significant problem, especially with aging. Also, our overuse of proton pump inhibitors, things like Prilosec and Protonix, Nexium, and then neuromuscular diseases. So SIBO, I mentioned, can cause problems with inflammation in the gut. One of these is tumor necrosis factor alpha, which increases gut permeability. Then we get basically a vicious cycle because the lipopolysaccharides that occur will open up and from the gram-negative bacteria, and then that sheds this shell that they live in, and those enter the lining, and LPS, lipopolysaccharides, increase hepcidin, it's known, and IL-6, one of the T cell cytokines, increases hepcidin. And what happens there? Hepcidin decreases transportation of iron, which we know is important. And in a study of using inflammation markers and inflammatory chemicals put into mice, the mice actually started producing hepcidin in the choroid plexus, that's the covering of the brain, and that led towards less iron in the brain. So here's one patient, 65-year-old man, and maybe some of you have seen this presentation before, but it's still dramatic because he's my first patient that I thought about using antibiotic therapy for restless leg syndrome. Whoa, that sounds pretty wild, but it really came at the time where I was learning a lot about SIBO and started theorizing about the role of SIBO in extraintestinal manifestations of SIBO. So I talked to him about a condition called post-infectious irritable bowel syndrome. I was treating him for IBS, and I knew that he had restless leg syndrome, but I didn't put the two and two together. But at a conference I went to in 2005, I found out that post-infectious irritable bowel syndrome was correlated with SIBO, and that SIBO also occurred in fibromyalgia. And then I realized that fibromyalgia patients had an increased incidence of restless leg syndrome. So I jumped from SIBO and post-infectious IBS to restless legs in SIBO itself. And so I talked with him. It turns out that he had very quickly developed irritable bowel syndrome after a trip to Romania, and he developed restless leg syndrome very quickly after that. I treated him with rifaximin, and he dramatically improved with respect to restless leg syndrome. Big problem was his PLMS or PLMD. It didn't change, which was unfortunate. And that's my cousin Steve. This is a drawing I made of him. And he's the guy basically who brought a whole 15, 16 years of research coming forth out of this observation. So that's one relative who has the problem, and I'll tell you about my wife in a little bit. It sounds like Henny Youngman. All right, so anyway, I looked at primary RLS patients and compared them to controls and asked, okay, you know, these patients didn't have restless leg syndrome, restless leg syndrome due to, let's say, Crohn's disease or pregnancy or any of the 50 secondary RLS cases and disorders. And basically 69% over here, 69% had a positive breath test compared to controls, and that was statistically significantly different. So the thought is that SIBO is common in RLS patients. This is how I treat SIBO. There are some questions regarding this, but I'll just gloss over this a little bit now. I use rifaximin most commonly when it's hydrogen-associated SIBO, and insurance is prone to cover it when there's an underlying diagnosis of IBS-D, irritable bowel syndrome with diarrhea, and failure to respond to other treatments. I like treating with low-dose naltrexone, which I'll talk about, and then I like preventing SIBO from coming back either by looking for the underlying disease like gluten-induced celiac disease or pancreatic insufficiency, or atrophic gastritis causing achlorhydria and lack of acid, and thinking about their surgeries that they've had that might cause problems, or whether the surgeries cause adhesions leading to SIBO, where my therapist, a physical therapist, is able to work out adhesions through the company called Clear Passages. Clearpassage.com deals with people with adhesions and recurrent small bowel obstructions and SIBO. And then there are 3 basic drugs that can propel the small intestine and activate it at night to sweep out the small intestine and keep it free of bacteria. Additional things that could be helpful is if you've had SIBO for many, many years, then zinc, L-glutamine, or the combination pill, Endozin, is possible. If it's very bad, I use serum bovine immunoglobulin, SBI, also known as Interrogam. Diet is important. We're going to talk about that a little bit with respect to what things are bad for you if you have restless leg syndrome. And then it's very important, obviously, to have a high vitamin D level with restless leg syndrome. That's actually a finding that's pretty recent, but guess what? Vitamin D is an anti-inflammatory moiety, and it decreases inflammation, which is so important in the setting of a lot of the diseases that cause restless leg syndrome. And then, of course, good old iron. Now, what about another epidemic or pandemic going on is the obesity crisis and the effect on restless leg syndrome. Obviously we worry about obesity and cardiac disease, but it does play a role in RLS. So here's an initial study, and look at the date. It's pretty recent, 2017. A possible risk factor for restless leg syndrome. They looked at 143 patients, and these were heavy individuals, 37. So 30 is 30 to 40 is significant. 40 and above is morbid obesity. So these are moderately severe obese patients. The similar age, and obesity increased the following issues: poor sleep quality, insomnia, depression, anxiety. But unfortunately, they didn't have a category for restless leg syndrome. But there is a study in adolescents looking at weight factor, and a large population, 157 adolescents. Prevalence of restless leg syndrome in those people was 5.1. Now, if you think about relative frequency or prevalency of restless leg syndrome being around 7%, but the increases to 10% with increasing age, 5% may be, expected. But basically, they did look at how their weight correlated with sleep problems and in their free RLS counterparts. So their conclusion was that adolescents with restless leg syndrome had higher body fat and worse sleep quality compared to thin adolescents without restless legs. Now, here's a study of a pediatric group of patients, children and adolescents, looking at RLS and sleep quality. And they looked at obese and overweight versus controls. And these were controls, who were not known to have restless leg syndrome. So they looked at prevalence of the condition. And prevalence means what percentage of people have a particular condition. So in the obese group, closely 22% had RLS versus overweight of 3 and control of 1.5. Their sleep quality index was higher. The poor sleep quality index was higher in the obese patients than the control group. So sleep disturbance and the frequency or prevalence of restless leg syndrome is significant in obesity. I mentioned vitamin D and inflammation. I mentioned Dr. Walters and my foray into determining inflammatory conditions that cause secondary restless leg syndrome. We're going to look at that, but also think about pro-inflammatory foods, because this, of course, is what you eat lecture. And fat, sugar, and gluten are known to be pro-inflammatory. So regardless of whether you've got SIBO or not, these are on their own important. Anti-inflammatory diets are listed here. That if you've tried everything or you're just getting terrible side effects from drugs, go on one of these diets. You could think about the Mediterranean diet or the strict low FODMAP diet or a gluten-free diet. The autoimmune paleo diet is a bit more hard to follow. So this is data from our 2012 paper. We looked at secondary restless leg syndrome, and there were over 50 conditions, but only 40 had a comparison group of controls to know that it was highly associated with restless leg syndrome. And I grouped them into neurological, GI conditions, rheumatological, metabolic, pulmonary, and then other conditions. And iron deficiency in total was present and reported in 25 out of the 40. SIBO had been tested in 15 of 15 different conditions, and all 15 were positive. And then in terms of inflammatory conditions like autoimmune neurological diseases, that would be an immune disturbance, or let's say rheumatoid arthritis, that would be an inflammatory autoimmune condition, etc. 33 of the 40 had highly associated factors of inflammation and or autoimmune phenomena. So just concentrating on GI, because that's what I do every day. If you look at the iron deficiency, SIBO, and inflammatory columns, virtually everything shows up as a positive. Gastric resection, where you lose the ability to absorb iron, it's not studied, but it's unlikely. Irritable bowel syndrome has been looked at, and IBS by itself, without SIBO, for instance, there is no iron deficiency. Gluten, one of the pro-inflammatory foods that we love, our pasta. We love our pasta. We love our pizza. Doesn't necessarily love us, though. So celiac disease was the first disease that I looked at in 2009. I looked at my 85 patients. Dr. Walters was involved in this study as well. We looked at the incidence and the prevalence. So if they've ever had restless leg syndrome, that's the incidence. And it was 35% of my 85 patients had restless leg syndrome at one point in time. When I was seeing them, it was 25% had restless leg syndrome versus 9% of spouses as a control group. And interestingly, 21% of the patients with restless leg syndrome preceded GI symptoms and a diagnosis of celiac. And in fact, one study that I was doing a long time ago, I had a 57-year-old woman who told me she had, GI symptoms since she was 5, 52 years worth of GI symptoms, and I was enrolling her in a restless legs study. And I said, have you ever been tested for celiac? She said, no. So tested her, positive antibodies, treated her with a gluten-free diet. Just saw her recently for regular screening colonoscopy. No restless leg syndrome and no GI symptoms since that study years ago where she was diagnosed with celiac. Celiac is known to cause iron deficiency, but in the patients that I was dealing with who had active restless leg syndrome, only 40% had iron deficiency. And so one possibility is it's the inflammation or the autoimmune phenomenon that occur in celiac disease that lead towards restless leg syndrome. And 50% had a rapid improvement with gluten-free diet. And looking at vitamin D, this is the one study that, again, only 3 years old. They looked at a decent sized population, RLS patients versus controls. And 76% of RLS patients had vitamin D deficiency. Vitamin D deficiency in the controls, that's common. I mean, we don't go outside running around in the sun. We don't take supplements. We don't drink much milk. And so it's not surprising. But there was a big difference between RLS patients and controls. And it was 4 times the likelihood, if you were low in vitamin D, that you would wind up getting restless leg syndrome. I don't know how many people are teachers out there or African American, but those are the situations where vitamin D is hard to absorb and get. So that was interesting as well. Magnesium, oh my goodness, magnesium. I talked with Dr. Walters, and he did a major study on magnesium, and he said there was some close situations where magnesium were found to help restless leg syndrome, but it didn't meet statistical significance. But I do certainly hear plenty from patients who say, if I take magnesium, my restless leg syndrome is so much better. So there was a systematic review of restless leg syndrome, PLMD, and magnesium supplementation. And this is what Dr. Marshall et al. Found just 2 years ago. Magnesium was suggested because of anecdotal evidence. Their patients said, hey, it makes me better. They looked through a lot of studies, 855 abstracts, meetings and publications, and 7 full text, and 8 full text documents. There was 7 that have to be removed because they were not locatable on the internet. Hard to imagine, but maybe they were old studies or in foreign languages. Anyway, 8 studies had relevant data. One was randomized placebo-controlled studies, and the other one were case series. And if you're a scientist, then you just have to have the randomized controlled studies to really believe it. Otherwise, there's a lot of skepticism in medicine, and people don't believe it. So unfortunately, the RTC did not find improvement with magnesium, but they said that study was just not, did not have enough patients in it to really be 100% sure. So they could not make a conclusion. So if magnesium helps you, continue it. There was a study looking at periodic leg movements and magnesium. It was open label. So again, the patients knew that they were getting magnesium and not a placebo, and their investigator knew that as well. So it was only in 10 patients. That's pretty little. But there was a slight improvement. And so therefore, you can't, I mean, if you haven't tried it, you should try it. And maybe we'll get more clinical data, and you could report that to the foundation and create a study. And the more studies we have, the better. So this was an extension to that study of 10, basically that the symptoms of sleep improved after treatment. Intravenous magnesium was reported in 1 patient. So this may be how it got started, with people seeing this one case report. In 2006, a woman came into the hospital. She had a 13-year history of restless leg syndrome. She had to go on bed rest because of preterm labor, but basically she was suffering terribly from restless leg syndrome, especially while at rest. So later on in the pregnancy, she comes in, she gets admitted because she's in preterm labor. One of the treatments for preterm labor is intravenous magnesium. Well, lo and behold, her RLS went away. Let's go on to caffeine. Lots of people need caffeine. This is water, by the way, because I don't need caffeine. Look at the year of the publication, 1978. This is one of the recommendations by the Mayo Clinic on their current website, not to have. 62 patients, was uncontrolled. It suggested that anxious, depressed patients that received caffeinated drinks worsened restless leg syndrome symptoms. Here's a study only 2 years in the going is alcohol. Restless leg syndrome, I'll just give you the background. It's important to know that in cirrhosis, there's an increased incidence of SIBO, okay? And alcohol makes SIBO worse. So that's interesting by itself, but basically they found out that restless leg syndrome was increased morbidity of cirrhosis, and the possible connection, of course, is that cirrhosis causes SIBO, and we do know this from older data. There's publications on SIBO and chronic liver disease. And SIBO, once again, is made worse by alcohol because the bacteria love fermenting the alcohol. I was about to say drinking the alcohol, but they don't drink it, they just ferment it. Also in alcohol, 2 other studies. One was a negative study. Another study was in PMLD, PMLS. It worsened PMLS, so it didn't address RLS. So if you suffer from PLMS, ideally you should not be drinking. Stevia, there are people who love stevia now in place of saccharin and sucralfate and the yellow packet. Restless leg syndrome was associated with stevia, but it was only 1 patient. Stevia actually made RLS symptoms worse with stevia. Stevia doesn't, to my knowledge, feed RLS, so this may be a chemical thing. And chemical things I'm going to just talk about in a second without a slide. Going back to saccharin, which is off the market, a person got worse with that. So what about chemicals? What about chemicals? Before I get into that, I think about my mast cell activation syndrome patients, where they are highly sensitive. Many of them have 10 different allergies to medicines, but it really is the chemicals, the binders, the food coloring, and the preservatives that's within the pill. It's not the drug itself. So a variety of chemicals can make mast cell activation syndrome worse. And if it's getting worse, then we get more chemical mediators that are pro-inflammatory, which then theoretically can lead towards iron deficiency in the brain, or chemicals going around causing inflammation, increasing hepcidin, and decreasing iron transportation to the brain. So those are some of my thoughts about why chemicals and a healthy diet are so important. To avoid chemicals whenever possible, and just think about the next product you consume. Turn the packet to the side and look at all the chemicals listed in that pre-prepared food. So what medicines decrease inflammation and restless leg syndrome? There is only one. Low-dose naltrexone is the only medication that decreases inflammation naturally and has been shown in small studies to help restless leg syndrome. Endorphins the body basically is tricked into making more endorphins. So the small amount of naltrexone that you take binds temporarily, and then it causes the cells to produce more endorphins, that would put more endorphins into the brain, which Dr. Walters showed were less than controls. And it increases the motility and migrating motor complex, thus helping SIBO. It decreases systemic inflammation by affecting the T and the B cells. Basically, many autoimmune diseases and inflammatory conditions, the T and B cells are revved up, and SIBO revs it up as well, and LDN reduces the T and B cell hyperactivity. And finally, we have these little cells that sit on top of sensory nerve cells. They're called microglia, and low-dose naltrexone blocks a receptor on that microglial cell and reduces neuroinflammation and neurosensitivity. Finally, some quotes about food, and I'll leave this up here just for your amusement. I'm going to say that I hope you've enjoyed what I've been able to impart in this lecture. I'm going to be coming back to you for help. So I am going to be asking the foundation to promote a questionnaire that I'm going to be giving out to RLS groups, Facebook groups, the foundation group, etc., to check off on this computerized anonymous questionnaire symptoms of mast cell activation. And this is going to be patterned exactly after a study that I just published. It's available in preprint form on mast cell activation in long COVID or long haul COVID. So people with long haul COVID or long COVID and get terrible symptoms and fatigue and brain fog after COVID actually look exactly like my mast cell activation syndrome patients with respect to severity and frequency of symptoms. Another journal is looking at our study that we submitted at the same time, that is the occurrence of restless leg syndrome in long COVID, and the idea that that is something that was important to study came out of looking at the long COVID groups where they were complaining, hey, now I've got restless leg syndrome, is this related? So we did that study, and it showed almost 3 times as many people from baseline got restless leg syndrome after their COVID infection. So that's pretty cool. And then finally, the study on restless leg syndrome in established mast cell activation syndrome was published in 2020. That's out there if you just Google or go to my website, gidoctor.net. There's information under other services, and that's where I've put down a lot of my publications. So I would want to finish with one thing. I'll talk about my wife, who for 3 years would say, I'm gonna go to bed now and have my nightly torture. And that's the exact quote and description that Dr. Willis wrote in 1695. Well, when I started getting into SIBO and LDN, I asked a neurologist about my wife's symptoms, severe pain, aching. She called it arthritis, but it was all throughout her legs. She didn't move that much, so she never got up and walked, so I didn't think, oh, this is classic RLS. But in fact, she would shift her body to try to get into a more comfortable position. The neurologist I was working with said, yeah, that's probably RLS. Did a breath test on her, she flunked it, as she liked to say. Started her on antibiotic therapy, dramatic improvement, put her on erythromycin to keep the SIBO away. Then she got put on a cholesterol medicine, so I switched her to low-dose naltrexone because erythromycin can interact with the cholesterol medicine, statins, and she did better. And so now it's been 11 years that she's been on low-dose naltrexone, 2.5 milligrams at bedtime, and she went from 3 years of suffering to 11 years of comfortable sleep if the dog lets her sleep through the night, but that's a different story. So I know it works, and I didn't put all the data, of course, which I did in the first talk, and you can go back to that where I go through all the studies that were done on antibiotic therapy and LDN. But if we can reduce inflammation, that's a great thing. If we can reduce inflammation in our diet and look for triggers, because you may be patient X with food condition Y, and you're the only one who can figure that out, that a particular substance bothers you. Because believe me, I have so many mast cell activation syndrome patients that they can't tolerate foods A through F, and it makes them have a flare. It increases their histamine level. It increases their restless leg syndrome activity, and yet a number of them do so well on LDN.
Awesome. Well, let's get going with some questions. Let's see. Are there any other foods that RLS patients should avoid?
Well, I think the histamine foods are important to think about. So the high histamine foods, for instance, alcohol, and this is actually another way to think about alcohol as being a problem because it releases histamine. And as I said, you know, that could activate your mast cells, or if you have a DAO enzyme deficiency, either due to damage to your small intestine, or you've just lost the enzyme, like people lose the enzyme lactose, lactase rather, you know, that could be why you're having high histamine foods triggering restless leg syndrome. So spaghetti sauce, tomatoes, cherries, meat that's leftover, salami, tuna, those kind of high histamines, and there's a lot more, are definitely things that could be the trigger.
Awesome. Is there a connection between acid reflux and RLS?
Conceivably. So we're given proton pump inhibitors like candy, and if it decreases the acid too much, that can cause achlorhydria. And with poor acid, then you don't kill off the bacteria you're swallowing. And so that's one way it can occur. And then the other is, and I hate to be a broken record, but you know, it comes with the territory. Because I have 300 mast cell activation syndrome patients, MCAS patients put out histamine, which increases acid production, which increases the risk of acid reflux. So yeah, there's several ways to think about this.
Great. Does a diet higher in protein help with RLS, or is it a detriment?
As long as it's fresh, I would say it's great. If it's leftovers, then that's a problem. As long as it's not, you know, something like salami or hot dogs where, you know, you might have additional chemicals or histamine in the product itself, that's an issue. So those are the basic things in that regard.
Alrighty. Does medication such as Pepcid improve SIBO and in turn lessen RLS symptoms, or does Pepcid make everything worse?
Pepcid does not make anything worse. Pepcid can reduce mast cell activation. Pepcid can reduce acid just enough to treat acid reflux, but not low enough to suppress the acid production to the point where you have achlorhydria. So yeah, Pepcid, let me see if I wanted to say anything about Pepcid. So Pepcid doesn't improve SIBO per se, except, we just don't know. I did a study looking at SIBO in the setting of MCAS. 30% of my 160 MCAS patients had bacterial overgrowth versus 10% of controls. And yet we think that's due to the activity of the mast cells next to the autonomic nervous system nerves that therefore would slow down the system. And therefore, if you treated that with antihistamines, it might decrease the activity of those particular mast cells and therefore have better digestion and better motility, and therefore less SIBO.
Great. I'm a vegetarian. Will my lifestyle choice have an effect on my RLS?
I think you're better off in general, except for 2 or 3 things. Number one, you got to make sure you're taking supplemental iron and B12. And I finally got through to my daughter who's a vegetarian, and she's taking her supplemental B12. And that's just important for general health and neuronal function, no matter where in your body. And iron, of course, it's going to be very hard to get iron if you're a vegetarian, and if you're menstruating, you can get iron deficiency and worsening RLS. And those are the main things for vegetarianism.
Great. I often felt RLS is related to what I eat. How do I know which foods to avoid or how to eat so it doesn't exacerbate my RLS?
Well, one of the quotes that should have been there is listen to your body. So I understand that there are potentially 400 people signed up for this and may go back, but you 400 people, if you listen to your body, if you say, okay, if I have decaf coffee, which always has some caffeine, or if I have ice cream at night, I'm going to have a worse night from my restless leg syndrome. Listen to yourself, because A, you may be unique, or B, you may have discovered something about yourself. Let's say you have underlying SIBO that you don't know you have, but your ice cream at night feeds the bacteria, increases inflammation at night, drops your iron in your brain, and then you get a bad case of insomnia because of the inability to get to sleep because of your legs.
Great. Opiates are widely considered a trigger for SIBO. I have SIBO and rely on opiates. What do I do to help this situation?
Okay, so opiates, very important. Yes, opiates help the symptoms of RLS, and God willing, you could even think about low-dose naltrexone, which does reduce pain in different parts of the body, arthritis, back pain, etc. And there's a wonderful article by Dr. Jared, and I think it's posted on my website as well, how it works to reduce pain. So A, could you use some non-narcotic for pain? And that'd be great. Yes, narcotics are great for severe restless leg syndrome, but they promote SIBO, and SIBO is bad, so we got a bad vicious cycle there. And then the other issue is if you've got constipation and therefore opioid-induced constipation, ask your doctor for one of the medicines. They're peripherally active mu opioid antagonists. Pamora is the short version name, Pamora, but that includes Relistor, Muvantic, and Simprolic. So there are 3 FDA drugs out there to get rid of constipation and probably small bowel dysmotility from narcotic use, but it still maintains the effect of the narcotic that you're looking for, namely analgesia, but it takes the gut dysmotility or the constipation, the bloating, etc., out of the picture by working on the gut receptors, but it doesn't get into the brain.
Great. We have time for 2 more questions I'm going to squeeze in here. Should an RLS sufferer with normal iron studies and no symptoms of SIBO be tested/treated for SIBO anyway?
My answer is yes. I encourage all my patients with SIBO to be tested. All my patients with restless leg syndrome to be tested for SIBO. The one study, again, it wasn't a big study, but 39 individuals with primary RLS with no good explanation for it. You know, they didn't have celiac disease, they weren't pregnant, etc. I could say etc. 38 more times. They had no reason to have restless leg syndrome other than being in that category of primary restless leg syndrome. 61% had a positive SIBO test. Now, are you going to be able to convince your doctor to do that? Well, you might be able to convince your gastroenterologist to order the test and get treatment if it's possible. You might be able to encourage your doctor to order a test. There's several tests that they just need to write an order for and contact one of the labs that mail you a kit, and then you mail the kit back to them, because in fact virtually nobody does it in their office except for centers like mine, but you know, so most of the testing is done remotely, and it's a good way to look at it, you know, and then we'll add data. We can add data to those 39 individuals. I would be doing more data if I wasn't so busy as a GI doctor working and doing other studies, especially on MCAS now.
Great. And this is our last question for the afternoon, and my favorite. What research are you currently working on?
So a lot of it is mast cell activation syndrome. In Germany, 17% of the population have mast cell activation syndrome. If you just hit the highlights, people who have neuropathy, restless leg syndrome, tinnitus, migraines, interstitial cystitis, irritable bowel syndrome, restless legs for no other good reason. Many of these people will be grouped together, and if you ask people, are you allergic? Do you have headaches with odors and strong scents? Do you have severe seasonal allergies that are year-round? Do you react to different medicines? Do you have chronic fatigue and brain fog? These are the groups of patients that group into mast cell activation syndrome. And there's a lot on my website on that as well. And it's exciting because it's led to many other studies looking at Tourette syndrome as far as neurological problem. And again, for those latecomers, I'm going to be looking for volunteers to fill out a questionnaire. It'll be anonymous, and it'll go through the computer to look at the frequency of mast cell activation symptoms in RLS patients. So that'll be coming your way. It'll be IRB approved. And I thank you in advance for participating in it.
Awesome. Well, thank you so much, Dr. Weinstock, for your time and for such a great presentation. And I hope everyone has a great rest of their day. And thank you so much for joining us today. Have a good rest of your afternoon. Bye-bye.